Welcome to the Health Impact session on public health. What we've seen over the last few months is that public health has gone from this thing that we used to talk about at the side in health hospitals, health systems, and other sectors to just becoming completely front and center, and for a good reason. So I'm really excited today to be talking with Dr. Lena Wen she's a public health professor at George Washington University, and we're going to talk a little bit about what was public health like pre-COVID? What is it like now? And just from a high level to set the stage, but then really jump into very, very specific questions about how does the world of hospitals and health systems strategy, tactics, and decision-making really need to change in this new era where public health is so much more important than it has always been. It should have always been important, but now it's come front and center very, very quickly for obvious reasons during the pandemic. With that, let me introduce Dr. Lena Wen. Lena, tell us a little bit about yourself. I know we see you on television all over the place talking to citizens and telling them how hospitals and health systems are doing. And let me just start off with you. Just give us a little introduction. Tell us how you're doing, because you're spending a lot of time with patients in this COVID era now.
Yeah, that's right. So thank you for having me today. So I'm an emergency physician. I still practice. I also am a public health professor at George Washington University. I previously served as the health commissioner for Baltimore. And so, I think this is truly unprecedented times for all of us. I'm also the mother of two. I have a 3-month-old and an almost 3-year-old. And so am navigating these times, I think, as all of us are, with balancing our family needs and the complex needs, I think, especially as we're thinking about coming back to school, reopening the economy, together at this really unprecedented time in our history. But to your point, just to piggyback on what you said in the intro, who would have thought that we would be here now? As we're speaking in July of 2020. If you had told us that we would be seeing over 135,000 deaths and 3.5 million infections back in January or February, when there were no cases at some point, it just would be, it's a night and day difference. And I think so much of what could be coming our way, that modelers and public health experts predict could be coming our way, will, unless we do something now.
Yeah, I think that's a great point. And just to personalize this a little bit, so you had a baby during COVID times. What was that experience like? If you can name the hospital, that's great. But tell us, what was that experience like that was different than your first baby, of course, that was not born during COVID times? And then tell us how are pediatrics and the family physicians, et cetera, handling this environment at this point?
Yeah, this is a reminder. Actually, my giving birth during the pandemic, I think, is a reminder in any of us who've sought medical care during this time. It's a reminder that we don't stop everything in the middle of a pandemic. You can't. This is not a one-time event. Even for something like a hurricane or a storm, you deal with it for a few days, maybe the recovery takes months, but you're dealing with a one-time circumstance, and the resources can be mobilized from all over the country to that one region that's hard hit. Now we know this is something that we're going to be grappling with, not just for weeks, but for months and maybe even for years. And for me, the experience, I had a child 2.5 years before this one, the same hospital here in Baltimore, and it was a night and day difference. Even the idea that up until the moment that I went in for labor and delivery, we weren't sure if my husband or anyone would be able to accompany me in the labor and delivery room. That's not something that we could have really ever imagined, giving birth alone. At the time that I was in labor too, we had a doctor and a nurse who tested positive for COVID, and a number of other staff were out on quarantine. And my nurse had been issued one surgical mask to wear for the week, a reminder of just the critical shortages that we're having in our PPE. And she and I were also talking afterwards. She said to me at some point, I'm going to see you in the grocery store and want to give you a hug, but you won't even know who I am. And I thought about this, and because she was, abiding by the mask wearing policy, I never got to see her face. And so I think, again, healthcare happens. We're doing things so differently. And I think it's also challenging our humanity in a different way. How many of our colleagues now, working on the front lines, have been with someone towards the end of their life And the best that we can do is to hold their hand and hand them a phone to be able to FaceTime with their loved ones one last time. I mean, that's something we could not have imagined before. And I think it's these unprecedented times that we're all, again, navigating together to the best of our abilities.
No, and I think, Lena, you guys are doing a fantastic job, especially all the frontline folks, very heroic in the activities that they're taking. You mentioned that there was quite different to give birth, but I also know that you've spent a lot of time, especially when you were at the Baltimore Commissioner's Office, you spent time on disparities. So there's one thing about a difference between pre-COVID and post-COVID, but there's also the post-COVID where different classes of individuals are getting different kinds of treatment. They're getting sicker differently. Tell us a little about what you saw on the ground with these kind of disparities. What is real and what was, maybe it was maybe sent to the extreme. Was it actual disparities? What's real out there? What's happening to different levels of folks, whether it's ethnically, race-wise, gender-wise, or maybe just by the kind of income you have. There's a lot of reasons for disparities, but some of it has got to be real, but some of it also has to be fake as well, right?
Well, I don't know if it's real or fake is the right way of putting it, but rather that there are rampant disparities. And I would put it as COVID-19 has unmasked long-standing disparities. In medicine, we talk about acute on chronic, that the conditions that we're seeing that are acute and new are actually, they're superimposed on top of ongoing chronic issues. And I think that's what's characterized here in COVID-19 as well. We know that there are huge health disparities. I mean, in my city, in Baltimore, there are neighborhoods just a few miles apart where a child born today can expect to live 20 years more or less, depending on the zip code they're born into, depending on the color of their skin. I mean, those disparities already exist. And we know that COVID-19, that people who are people of color, or African-American, Native American, Latinx, they tend to be essential workers and don't have the privilege of social distancing. They may live in multi-generational crowded housing, where it's very difficult to self-isolate if you are ill, or quarantine if somebody else gets sick. Also, that we know COVID-19, the people with the most severe effects are those who have underlying chronic medical conditions. Well, why do people have these underlying conditions? In my city, 1 in 3 African Americans lives in a food desert compared to 1 in 12 whites. So is it any surprise that African Americans have a higher degree of diabetes and cardiovascular disease? And so you have all of these factors, one on top of another. And I suppose at this point, it should not be a surprise, although it's so tragic that we have these amplified disparities that we're seeing in both exposure and infection rates, as well as death rates for these same populations, these communities of color that are socioeconomically vulnerable. And so I think at this point, though, there is so much discussion on the problems that it is really important for us to zero in on the solutions. There are actually tangible things that we can do to close that disparity gap. So for example, around testing, we shouldn't just be looking at the testing rate overall. We should also be looking at the testing rate specifically divided by demographic and as close to a community level as we can. Because maybe you'll find that in a metro area that the testing level, the test positivity level is 5%. But what if for African Americans, it's 20%? What if in one particular zip code or one particular area, the test positive ratio is 40%? It means that we need to be doing a lot more testing that's focused specifically in these areas. We also have to be doing things like worker protections, because we know that these essential workers tend to be people of color. So we can also be raising the alarm about the enforcement of worker protections in these jobs. Why is it that only doctors and nurses, for example, are getting PPE? We should also be ensuring that teachers have PPE, that bus drivers have PPE. And so I think those are the types of things that, yes, they overall aim to improve health for everyone, but specifically will make the most difference on those who unfortunately are suffering the most as a result of this pandemic.
No, I'm glad you said that, and because so the way I set up the question was to make sure you made the point. This is not an exaggeration. It isn't. There's nothing fake about this. I mean, this is very, very real. And in another way, there are some pockets. You know, a homeless problem might seem like something you could kind of like push to the side. A problem of food deserts, you could say, okay, that's a geographic problem. pandemics are not geographic problems. Like whatever problem you have in one part of the city, you're definitely going to take to the other part of the city, because we do have social migration as people move from parts to parts. So is there a model where you feel that just by spotlighting the attention, that leaders get it and then they act on it? Or are we still seeing some detriments of leaders saying, okay, well, there's really nothing we can do about this right now. That's a social worker problem. It's somebody else's issue. Or do you see that we are taking this very, very seriously, where we see that if we don't, every class of individual here is equal to the virus? And I don't think we're all getting that just yet. And so leaders are making different kinds of decisions for different ethnicities, different races, et cetera. Do you see that as a problem, or am I exaggerating?
I mean, I think that we've seen leadership that's been exceptional during this crisis, and we've seen just the worst examples of leadership too. Actually, I think some of the best leaders in this have been state and local officials and individuals who have said, look, I realize that there is failure of federal leadership and there's so much that should have been done, but I can't change that. And so what I'm going to do is, with whatever resources are at my disposal, I'm going to do that. I'm going to take the bold early actions, for example, to implement social distancing that were really unpopular and really difficult and economically posed great challenges, but were instrumental in making sure that our hospitals do not become overwhelmed and doctors and nurses and clinicians get put into the untenable position of choosing who gets very finite resources, right? And so I think we've seen really good examples of people making these hard decisions. I think also we've seen hospitals and healthcare leaders step up too, to say we recognize that our public health infrastructure is lacking because of systemic disinvestment in that infrastructure, and so we would hope that that there was a lot more done by cities and counties, for example, on testing. But if they're not able to, we are going to step up and fill that void. And I think that's the kind of thing that needs to be done even more at this time. I wish that there was a national strategy from the beginning on testing. I wish that we didn't have 50 different states trying to figure out contact tracing when that's actually the bread and butter of public health. I so wish that we never got into this unthinkable state of running out of PPE. I mean, I just could not believe when my colleagues and I were asking over Facebook about whether our friends can go to a Lowe's or a Home Depot to buy us a respirator mask because we don't have any in our hospital, and trying to fashion gowns out of rain ponchos. I mean, we didn't think that that could happen here in the US. It's a national disgrace. It was a national disgrace the first time around, and it is a national disgrace now and moving forward. And so I think these are the types of things that we need to really speak up and be vocal about. And I think for local leaders, for hospital leaders, for startups, for others, the key is to step up wherever it is that we can, because if we're not going to get leadership in other ways, we have to be the ones to, we cannot wait for the cavalry to arrive. We have the ability to save lives now.
No, I think you're so right. It was interesting that in the first few months, so I'm a digital health professional. I work a lot in healthcare information technology and government IT and these kind of systems. And I actually had to come in, make connections for hospitals and health systems to get their supply chain, to get the PPEs. And I'm like, what is a digital health professional doing talking about PPEs in general, like talking about it, let alone assisting with the supply chain and finding vendors and those kind of things. So you're exactly right that the local leadership, probably this is their time to shine, and many of them are shining. So given where we are, what is and the fact that we don't actually have a national testing strategy, what can actionably local folks do to begin their local testing strategy out to a group testing strategy, and then to counties and up to the state? Who's doing it right and who's not doing it correct? And what would you recommend local folks start to do? Should they find their own equipment? Should they find their own labs, or anything else specifically that they can do?
Yeah, I mean, it's been a struggle. This testing strategy, I've heard others, including Dr. Sanjay Gupta on CNN, talk about this as the original sin of this was where everything went wrong. I mean, you think about a country like South Korea that had its first diagnosed case of coronavirus on the same day that we did. And look at where they are now with some 300 deaths overall compared to our 135,000 deaths. I mean, it's unbelievable. And it did originate because we never had a testing strategy to start with. I mean, I think that testing as a start needs to be the following. It needs to be widespread. It needs to be free, it needs to be easily accessible. The results need to come back that same day. It's 24 hours is the uppermost limit. You can't have something come back in 7, or in this case now in 10 days. I mean, what good is that result going to be? Also, the testing needs to go to where people are, especially in communities that are the hardest hit and where people have many barriers to healthcare anyway. You cannot have only drive-in testing. You also have to have walk-in testing. Ideally, it's also done through mobile vans and in partnership with trusted messengers in the community, including churches and community centers. And so I think all these strategies need to be employed, and I would certainly hope that and I know that many hospitals across the country are already doing this, but the more that they can think of these creative outreach strategies, and the more that they can also be really zero in on that test positivity rate, break that down by demographics so that you do know, is there you just don't want to get the general sense, oh, we're testing fine, the positivity rate is less than 5%, but in one part of the city or with one demographic group, you're not reaching that group at all. And so I think that's something very tangible that people can be doing. I also think that, again, at this point, we cannot wait for a national strategy to occur. So I would encourage everyone to pilot what they can, innovative strategies, rapid testing, and hope that the innovations, I think, are going to come from hyper-local places, from individual hospitals, startups even. They can then be scaled up accordingly. It's not going to come from a national top-down approach.
No, and I love that advice because if you think about it, there's a few key areas where testing can fail. One is the facilities aren't available. Another is that equipment is not available. Another could be that personnel to run the equipment at the facilities are not available. But I love the idea of the point of care testing that you just mentioned. How real is that, and what kind? And you're welcome to mention vendors, startups, or anything that if you feel comfortable doing so. Tell us where point of care is working, that you've actually seen it work, and it could be scaled, but because of our reticent, and this is when I say our, I mean the royal we, as in healthcare, we like to do things only when it's very, very safe, which is normally a good thing to do, but we can't transform for as fast as we need to during the pandemic if we take the amount of time like we did before. So I know that the FDA has offered emergency use authorizations, or EUAs, for a number of them. Talk about the point of care testing a little bit and tell us where that's succeeding and maybe not going so well.
Yeah, I mean, I think there are some innovations that are occurring in the space. I very much agree with you. I think we do need point of care, ideally point of care testing with the results that can come back within an hour. But at the very least, we need some type of testing that can come back within 24 hours. And so I think that the balance has to also be accuracy. Right? Especially, we do not want something with a high false negative rate. When the initial antibody tests were coming out and the FDA gave the emergency use authorizations for these antibody tests, when you have a false negative or false positive rate of 50%, I mean, then it invalidates everything. And I think also in this time of science denialism, the last thing that we want to do is to have the credibility of our scientists and our medical folks be at fault here. And so I think there is just a careful balance that we have to strike. I think that there may be different uses also. It's possible that maybe for patients who have COVID-like symptoms or who have had exposure, that they need a more accurate test, and that you would make the trade-off that they have to wait 24 hours for a more accurate test, versus if it's used for people with a pretty low pretest probability. And these are individuals that you're using for screening purposes. Let's say it's you're screening them for return to work, screening them for an elective procedure, that maybe you would be willing to tolerate a higher level of inaccuracy, if you will, in order to do this screening quickly. And so I think it's going to be a balance moving forward.
Yeah, no, and from a balance perspective, how do you think we should look at the private sector or the technology sector in these kind of planning? So when you look at the way that we've always done things in the past. It's always, obviously we use a lot of private technology, but it goes through a set of processes and procedures before being brought into hospitals and health systems. So if you look at it now, what do you think is safe enough versus not safe enough? How should we make that decision? There's no easy answer that says this will be safe and that won't be. What is your general viewpoint on the private sector, what they could be doing right now, or maybe where they're being harmful right now?
Yeah, it's an interesting question, and I'll take the first part about about risk calibration, because actually that's the nature of everything that's happening nowadays. Even when we think about our own activities, we're thinking about activities like going to the gym, going to a restaurant, sending your kids back to school. Nothing that we do is going to be zero risk. But there are certainly things that we can do that are higher risk than others. And then there are things that we can do to mitigate that risk. And I think that this is a similar type of decision point when it comes to diagnostics and treatment and vaccines as well. That I think everybody is eager to get the next thing, but that also has to be very carefully balanced with what is the risk of that going the wrong way. And I'm not sure that I have an answer for this, except that it's not, we don't always want to sacrifice caution for speed. I've been thinking about this a lot in the vaccine space too, that, we really, at this time, again, when there is a vaccine anti-vaxxer movement, having something come out that's not safe and not effective and giving people false reassurance, that would actually be a worst case scenario that we want to avoid as well.
Yeah, that makes sense. And so as I think about this, and as a technician, as a startup and an entrepreneur runner, basically, what I like to see is that if I do put something out there, I've got enough real world transparent data with telemetry that can give the kind of like the performance and the real world ability for it to generate the data and give it to physicians like yourself. How do you see working with startups and technology professionals to guide them and say, hey guys, okay, I'm going to take this early, but here's the data that I need. Like the FDA, often when they do the EUAs, they say that, okay, you get the emergency use, but here's how I need the data to tell me whether or not what you're doing is safe and effective. But given that we can't have a national strategy, and you've recommended, rightfully so, that local professionals start to think about these out-of-the-box ways of doing testing and getting results, how should they work with technology startups such that they can go ahead and put something into use, but have data that tells them things are not going well? Are physicians trained well enough to be able to look at data coming back from these kind of new systems? Or do we need to get more physicians into the startups and in the entrepreneurial world together to work and say, well, we're going to work with Lena and this startup, and together we're going to work on some new ideas, plus the telemetry or the results in the real world data that come in, so that something that comes out fast is also safe?
Yeah, I mean, I think we're in unprecedented times when there are so many different studies that are being done every day. I mean, there are dozens, if not hundreds of studies being published every day about coronavirus. And so you were asking about clinicians interpreting data. We know how to interpret studies, but who has the time to be reading hundreds of studies a day? And then we're also seeing this new phenomenon of these preprints, of all of these different preprints, which I understand, right? I mean, we want to get the information out there. We don't want to wait. If there's a great treatment or a new study done about the way that the virus is spread, we don't want to wait until it's gone through peer review and then gets published months later. But in the meantime, though, that's a lot to wade through. And I do think that that one of the words that you said is so important, that's transparency. So the more transparency we have, the better. And I think that having all the information out there, not just having a press release with select data, but having all the data out there will be important, but also recognizing that it is a really challenging time to be a clinician or to be a public health expert too, because you do have a lot of different things flying at you at once. And frankly, that's the work that the CDC should be doing. Their job is actually to synthesize these very complex data and formulate guidance accordingly, but we have not been hearing their voice in the way that we really should be during these times. They have been,
and of course, we're going to hear less of it going forward now that the White House has asked data to go straight to HHS. Talk about that a little bit. Is how big of a danger is that, or is the danger exaggerated for the data not to go straight to CDC but to HHS? Any comments on that?
Yeah, I do. I think it's extremely concerning and frankly inexplicable. You have the top experts in the world at the CDC, so much so that other countries have named their top disease-fighting institutions after the CDC. There's Chinese CDC. There are other countries named the CDC who train their researchers to come to work at our CDC. These are people are the best in the world. They have the infrastructure set up for exactly a pandemic like this. So first of all, it hurts our ability to counter and fight this pandemic by making this move. But also, I really then worry about the data, because you should be able to trust the data. The data are objective. The data are based on science. If it's now going to a political entity and you're now seeing data that are coming out, I'd be very worried that the data are not accurate, that they're being used for a political or partisan means, that they are cherry-picked to make a political point. And there's no place for that, period, in our history, but really no time or place for that in the middle of a pandemic that's killing hundreds of people and could soon kill thousands of Americans every day.
Yeah, that makes sense. And when you think about, so what's the difficulty if we just say that we, in the healthcare community, we can crowdsource this data directly from hospitals into a peer-managed network? In addition to, obviously, the law is the law and we're all going to follow the law. And if the law changes to send it from CDC to HHS, of course, we're all going to do that. What's the harm in us taking that exact same data and sending it across a crowdsourced peer-reviewed model, put it on the blockchain, put it in a distributed database, stick it up on Amazon, wherever it goes? What is that crazy thinking, or is that possible for us to do?
I think it's a terrific idea. I think actually, as you're speaking and I'm thinking about this, I think this is exactly what should be done at this point. That way, it can also serve as a way to hold accountable HHS and other entities, because if it looks like they're saying, for example, oh, there's plenty of bed capacity, our ICUs are not getting full. But we can see, based on the crowdsourced data, based on this being transparently and openly available, that that's not the case. That's a way to call out the administration and say what is actually happening. And look, for me, none of this is political at all. This is about saving lives. This is about fighting a once-in-a-generation infection. This is something that all of us as scientists, doctors, administrators, etc., this is our fight. A public health crisis should be led by public health experts. And this is a way for those of us who are on the outside of the administration, who are not beholden to the administration, to hold it accountable, and more importantly, to do the important work that we need to do.
Yeah, and I think that, especially you've got such great credentials from the public health side. I think as you guys start talking about this idea, I mean, public health, so one of the ways the CDC has benefited us in the past, of course, it's always been nonpartisan, mostly scientific, et cetera, but it's still been bureaucratic. So even if the CDC was doing its job perfectly, I get the sense that doing crowdsourced data to make it fast and reactive, it also makes sense, right? To put a check on any government body. And if you talk about it a little bit more, I'm happy to jump in and help institutions set this up. I've had a number of discussions with different hospital administrators. They're interested in the idea, but we can't seem to figure out, where would you send the data? How would you make it occur so that, it happened in a peer-to-peer way? And the biggest problems that I've talked to CEOs especially about is, well, I don't want my competitive hospitals to know what's going on in my hospital. And so if you send stuff to the government, of course, they have a shielding requirement for privacy, et cetera. But at the same time, I think there's a way for us to share this data so that it's not for competitive or anti-competitive reasons, I should say, but for scientific and exploratory discovery and those kind of reasons. So it seems to me we're going to have to take, this bull by the horns, as you mentioned a little while ago. We don't have a national testing strategy. Basically, at this point, we don't have a national data strategy either. So we're going to have to assume the rest of us have to get to do it. And now what's the nice thing is healthcare has always been local. So do you agree that maybe it doesn't even have to start nationally? Just the 4 hospitals in a single city could start sharing their data. and get the kind of checks and counterbalances that they need, that they would have gotten from the CDC? Does that make sense to do locally, or would it not make sense unless you did it for a large group of people?
I mean, I think that one of my aphorisms that I often use is that perfect cannot be the enemy of the good. And so we need to do whatever it is that we can, and recognizing that this is not a time for us to be competing with one another. We are competing against the virus. And right now, the virus absolutely has the upper hand in all of this. And so we need to see how much the work that we do is about our individual actions and our collective futures.
Yeah, that makes sense. So as we conclude this section before we start taking questions, if you had a couple of pieces of advice, you know that a lot of our Health Impact listeners are senior leaders at hospitals and health systems. What are the couple of pieces of advice that you would give them around things like, should they care a lot about contact tracing now or not? Should they more focus on testing? What are the areas that you would just recommend them to maybe prioritize 1, 2, and 3? And especially for those areas where the positive test cases are growing. In other cases where it's stable or declining, not so much so. But for any areas that's growing, what are the 1, 2, or 3 things that you would suggest that they do?
Yeah, so I do think that it is important to separate out between the places that are the hotspots and the places that are doing relatively well. The hotspots for places that are actively undergoing surges, I mean, I think hospitals are already doing the right thing in terms of increasing their ICU capacity as much as they can, making sure that there is enough PPE. I think also our healthcare workers are exhausted. They've already been fighting this pandemic in some areas for 6 months, and there's no end in sight. And so making sure that we take care of our providers, taking care of their well-being and recognizing the challenges that they have also with childcare, with taking care of elderly parents, and the mental strain that they're under is going to be really important. For the places that have not yet hit that surge, now is the time to prepare. And I know that everybody is doing this already, but I think it's also important for all of us to be involved in public education, because we are, as clinicians, administrators, we are the trusted voice. We are the ones that are seeing what's happening on the ground. We are the ones who can counter these very harmful messages about how this is just like the flu, or how people will be people will not be harmed by this virus. I think there is so much that we can be doing right now to educate the public, and recognizing that what is going to come our way with the potential tens of thousands, if not hundreds of thousands more deaths, it's not inevitable. But it's up to us to work on saving people's lives when they come to us in their time of need, as well as preventing people from getting ill in the first place.
All right. Well, that was terrific. Dr. Lina Wen, thank you so much for spending time with us, and especially that nugget of advice of take care of the care providers, right? Because if we don't take care of them, this is going to get much, much worse before it gets better. So that's terrific advice. And so we appreciate it. We're going to turn it over for questions now, and we'll open it up at this point.